Chapter 9 is about articulation. So again, we're not strictly speaking lecturing on Chapter 8. I'll lecture on a couple of details from that, but otherwise it's a list of bony features. So you'll work on that in our sort of laboratory context. All right, Chapter 9, articulations. Most of talking about articulations is talking about how we classify articulations. We really like categorizing things as humans. We really like coming up with very specialized vocab for, what does this mean? What does that mean? How can we categorize it this way? How can we categorize it that way? So the bulk of your work studying for this chapter is going to be, how is it categorized this way? How is it categorized that way? How does this category apply to that category? And that's really most of it. In fact, I'll just show you right now. This chart right here, slide number 6, is the bulk of your exam content for this chapter. And this is showing you structural characteristics, structural categories, examples, and functional classifications. So you've got a few classification systems on this table. And the point here is going to be to say, okay, if it's this type of functional classification, what's its structural category going to be? And vice versa, things like that. Like if the nature of this is that it's less mobile, then because it's fibrous, then how are we going to call that as a structural classification? They are going to be connected, even though they're different categorization methods. Does that make sense, big picture for now, before we start going forward? Somebody give me a nod or a smile. Okay, there we go. Thank you. First thing in the morning. I know it's like this. Okay, so we'll talk about articulations in general. It's not rocket surgery. It's just where bone meets bone. They're going to connect somehow. They're going to have a lot of different ways that they connect, though. So we'll talk about fibrous, cartilaginous, and synovial joints, and some of the different ways we categorize those three types of joints. Synovial is going to be our biggest category in general, so we will go into selected articulations in depth. There's going to be, I think the hardest part about this is going to be to say, what do you want to know about those selected articulations in depth? I'm going to show you the linguistics approach to understanding the ligaments. You don't really have to memorize any of the ligaments, at least not in this class, at least not at this level. I think it's useful if you are interested in a field related to joints in any way, shape, or form. Orthopedic surgery, something like that? No, probably not. Okay, it's all, down to the individual. It's interesting stuff. I think you can get away with a linguistic approach to the ligaments 90% of the time, because they are all called the thing that goes from the thing to the thing. And that's really it. And I'll show you what I mean by that. So an articulation is a joint. It's a place where bone meets bone, or bone meets cartilage, or just teeth. Teeth have their own special category. Articulations vary in stability and mobility. So you're going to see this chart as your first concept today, and I think it's a pretty intuitive one. The more mobility you have, the less stability you have. So for example, your most mobile joint is probably your shoulder joint. And does everybody here know somebody or is somebody who has shoulder problems? Yeah, everyone, right? Everybody's got shoulder problems. This is the most mobile joint, so it's the most fragile joint. Our second most mobile joint is the hip joint, and it also has the brunt of our weight on it very, very frequently. So we all know somebody with hip problems, right? So the more mobility you have, the less stability you have. On the other hand of the spectrum, just big picture, the less mobility you have, the more stability you have. Nobody that I know of has ever dislocated their mid-sagittal suture, right? That's not really a common thing. Probably somebody has somewhere. It's plausible. It's just probably not very common. So our first classification is going to be by structure. Is it fibrous? Is it cartilaginous? Or is it synovial? And when we say, is it fibrous, do we mean, is it held together by dense, regular connective tissue, a dense, regular fiber? Is that what's holding it together? And that would be the only thing holding it together. So an example of that would be your sutural joints. They have nothing there except for some dense, regular connective tissue holding them together at the microscopic level. There are cartilaginous joints, and by that we mean that there's some kind of cartilage holding them together. And again, cartilage without something else there also. Because we're going to see in synovial joints, there is cartilage in synovial joints, but you also have the detail of the synovium, which is a fluid-filled cavity. So again, synovial joints will have cartilage, but they are their own category because they have additional structures aside from cartilage. So cartilaginous joints, intervertebral discs would be a good example. That's entirely fibrocartilage between those. They are not synovial. In synovial joints, we're going to have quite a bit of detail in terms of the structure of a synovial joint, a little bit more vocab there. So our second classification system is going to be by mobility. And it's a kind of a different naming convention. I don't think it's Latin anymore. I could be wrong about exactly where these words are coming from. But syn, S-Y-N, synarthrosis, means without movement. Amphiarthrosis means slightly mobile, some mobility, some not mobility. A degree of mobility, and again, considering this, you have some mobility and some stability. It's an intermediate form. And then you'll have a diarthrosis. Diarthrosis means freely movable. So your shoulder is freely movable. It's synovial too. So that's going to be the next thing we get to is, if something is synovial, it's almost guaranteed to be diarthrotic. You're very likely to have something with a synovial cavity. That synovial cavity is there to provide a lot of mobility. Whereas a fibrous joint, most likely, will be synarthrotic without movement. You're not very likely to be able to mobilize your fibrous joints. There are some gray areas that we'll see, and some of these gray areas are our sources that Jenny and I have where we're kind of mad at this chapter for being argumentative and saying something is, amphiarthrotic as opposed to diarthrotic, and some of those disagreements come in there. What's that? Yeah, does anybody have their book on them today? That's the new edition? Okay. We can look into it a little bit later as we get into it. Yeah. If you got it from this semester from the bookstore, then it's the new edition. Okay. Okay, I will come back to this slide because we're going to get into some sub-classifications within each of these structural classifications. You have several types of fibrous joint. Gomphosis is very specific. Gomphosis is teeth. Your teeth in your jaw, maxilla, mandible, that's a gomphosis. All of those joints are gomphoses. That's it. If I say gomphosis, it's teeth. If it's teeth, it's gomphosis. You're done. You're done with gomphosis. And it's a fibrous joint. And if you've ever had braces, you know that this joint does really not want to move, right? So we're going to call that synarthrotic. Sutures are one type of fibrous joint. And again, we don't really move the sutures. There's some, craniosacral massage therapists who think you can. It's very much up for debate, question mark, to those people. I would argue that in an adult that is a fully formed sutural fibrous joint, that should not be very movable at all. Craniosacral therapists have a belief where just very, very light pressure can shift the plates of the skull and move your cerebrospinal fluid and redirect it. And I'm going to try to stop being demeaning now, because I worked in that field for 10 years, so that was fun. Okay, syndesmosis. So be careful with this vocab here. You've got a synarthrosis and a syndesmosis. So that's going to give you a little bit of a complicating feature, right? I'll start with SYN. And the thing about the syndesmosis is that it's actually the most mobile fibrous joint, whereas this vocab word over here, synarthrosis, means an immobile joint. So it's a little bit of a tough one to internalize. So a syndesmosis is going to be a joint between two parallel bones. You'll only see them in a couple of places. You have your radius and your ulna, and yeah, you have your tibia and your fibula, and I'm always going to enunciate that because you will get them backwards half the time. For it's tibia and fibula. Okay. They're parallel, and in your arm, there has to be an articulation between the radius and ulna. It's not just the hinge joint here. Your arm moves in a different way. With this is called pronation and supination. So because these two joints are articulating, they are mobile, even though it's just fibrous connective tissue crossing over here, it has this mobility right here. It's some mobility. It's amphiarthrotic. It's not like this, but there's movement. Does that work for everyone? Syndesmosis is amphiarthrotic. Gomphosis and sutures should be synarthrotic. When you get to your cartilaginous joints, you've got two options there. And again, we've got this prefix syn, syn, but now it's synchondrosis. Again, synchondrosis versus syndesmosis versus synarthrosis, and they'll have very different meanings, so be very careful. Synchondrosis means bones joined by hyaline cartilage, and here's a gray area. They're calling this synarthrotic. There's one condition where I agree with that. The epiphyseal plate is an example of a synchondrosis between this ossification center and this ossification center. There's endochondral ossification. That is considered a synchondrosis. These two bones are connected only by cartilage. And that's not going to be mobile. That's not going to be very mobile. It may be a little flexible, but it's not part of your moving around, right? So I agree that that is an example of a synarthrosis. However, one place I disagree is that the costochondral joints are synarthrotic. Because can you move your thoracic cavity at all? Yeah, you can. So I disagree with that one. Anybody else disagree with that one? That there's, yeah, okay. So if I do allow for gray area, there's not an exam question where those gray areas are not taken into consideration. It's not going to be, there is not a question along the lines of, is, you know, the costochondral joint synarthrotic or amphiarthrotic? That's not on there. Because it's a gray area, I would not have that question on there. It doesn't come up like that. Your other cartilaginous joint is a symphysis joint. And I've kind of already mentioned this. Today we're going to see the pubic symphysis. You're going to see the pubic bones of the os coxae. We're not going to call this the pelvis anymore. This is going to be the os coxa, or os coxae starting today. And between them you have a pubic symphysis. And that's a fibrocartilaginous disc. And it's just like the fibrocartilaginous discs within your vertebrae, within your vertebral column. So anything where the bones are joined together by a pad of fibrocartilage is amphiarthrotic. You could use either one of these as an example for a symphysis. This one has the benefit of being called the pubic symphysis, so it's in the name. You can't really get lost on that one. If I ask you what type of joint a pubic symphysis is, you should be able to tell me symphysis. Your intervertebral discs are also symphysis joints. And those are considered amphiarthrotic. And again, there's a little bit of a gray area. General day-to-day activities, we say that there's no movement at the pubic symphysis. There is a context in which this becomes more mobile, and it's slightly horrifying if you guys want to know about it. Yep, all right. So during pregnancy, women release a hormone called relaxin, and it loosens up all of those joints. And the aim of that is to loosen up that pubic symphysis and widen the birth canal. So as a woman's pregnancy continues, the stability of her pelvis is lost, and she starts walking like this with her pelvic bones, her os coxae, going like this a little bit. And they can kind of misalign when that heals after pregnancy too. That happened to my sister, cause a lot of pain. Body horror. Hooray, pregnancy is scary. All right, that's not the thing that you guys should take from this class, but it's what I take from it. Okay, relaxing is terrible. It's also part of why women's feet grow when they're pregnant. It's because their joints are all relaxing and spreading out. It's not that their bones actually got bigger. It's that their joints spread apart.
I totally wondered that.
Yeah.
That's weird.
Mine never grew. Yeah. Mine didn't shrink down. They went up to half size.
Mm-hmm.
I was just staying down.
Yeah. Okie dokie. On to synovial joints. Your synovial joints have some general anatomy, and they have quite a bit of options in terms of forms they can take on. So let's do the general anatomy first. I should have a picture. Here we go. Providing stability, you're going to have ligaments. Today we're going to talk about the difference between tendons and ligaments. Ligaments link bone to bone. If it's going from a bone to bone, generally we call that a ligament. If it's detaching a muscle to a bone, we call that a tendon. The way I fit that into my head is that tendons tend to muscle and bone. It works for me. So that ligament is going to be part of a joint because it's connecting a bone to a bone, and it's going to be surrounding this entire synovial capsule here. So this purple bit here, this is the synovium. You have a synovial membrane that covers and lines the entirety of the joint cavity except where you have articular cartilage. And it's going to be very much like that serous membrane that you have lining cavities, in that it's going to secrete a fluid. It's going to secrete, now we're going to call it a synovial fluid instead of a serous fluid. It secretes that fluid into this cavity to provide cushion, support, protection, prevent friction. All of the same fluids we had in our body cavities, or all the same roles of those fluids in the body cavities. Then we do have that articular cartilage. Do you guys remember what type of cartilage is found in articulations? Are these articulations at the ends of long bones? Hyaline cartilage. So this is hyaline cartilage. Let's see. Also pictured that fibrous layer with the ligament and the synovial membrane. That makes up your articular capsule, so this will be fully encapsulated. And again, that fibrous layer will be covered by that ligament. Also pictured is the periosteum, also pictured is some yellow bone marrow, because this is just one bone and this is another bone. So every synovial joint will have different bones involved, but these same exact structures. There can also be a couple of extra structures depending on the location. You may also have bursae. Now a bursa is basically a little sphere-ish of synovial membrane that secretes synovial fluid, and it's going to be located in a location that is stressed, somewhere that's going to experience friction. So over major bony prominences. If a ligament is sliding over a bony prominence, that's going to be a site for irritation, and you may have a bursa there. Tendinous sheath is going to be similar. It's still an enclosed space of synovium, and it's still there to prevent friction in something that's moving around a lot. So these flexor tendons are sheathed with a tendon sheath as well. And many locations have fat pads. If you ever watch an arthroscopic surgery, you'll see them having to move through a lot of fat, a lot of adipose tissue. Your adipose is a cushion and it's structural support. You have, for example, a lot of adipose in your orbit, in your eye socket, just holding your eyeballs in place, right? So it's protective, it's supportive, it's an energy store. You're going to find that in a lot of joints as well. You'll find it in your knee, for example. So again, all synovial joints will have these. Some synovial joints will have these. And who's heard of bursitis? Yeah, so what's bursitis going to be then, logically? Inflammation of a bursa. So you could have a bursa on any, you have a variety of bursae within your shoulder, and any one of them can become inflamed if they become irritated, or infected for that matter. So again, ligaments connect bone to bone. They are made of dense, regular connective tissue. Sensory nerves, these will be innervated. Blood vessels are going to nourish tissues in the joint. Fun fact, adult hyaline cartilage is not vascular. It is avascular. And that means if you injure or damage this cartilage, it's not going to heal very effectively. It's receiving nutrition from that synovial fluid, from any nearby blood vessels, simple diffusion. It's not going to be the most successful at healing. Okay, any questions so far? And we haven't even done different types of synovial joints yet. So do we want to go over any of the other categories before we go into the very, very broad category of synovial joints? Nope. Okay. What's a synchondrosis? Give me an example of a synchondrosis. What about your ribs? Epiphyseal plates is absolutely an example of a synchondrosis. The joint between the rib and the sternum, specifically the rib to the cartilage, is costochondral joints. That is correct. And the joint between the rib and the sternum, costochondral. Good. Yes, those are synchondrosis. Generally, by your textbook, considered synarthrotic, but I think it's a gray area. Okay, what is a syndesmosis? Between two parallel bones. What are your two sets of parallel bones in your body? Between radius and ulna, and tibia and fibula is correct. How mobile do we consider those? Which thoracic are they going to be? Synarthrotic, amphiarthrotic, or diarthrotic? Amphiarthrotic is correct. Okay, what does synarthrotic mean? Without movement. Great. So types of synovial joints. We can talk about just planes of movement, but we're going to go much deeper than this. Uniaxial means one plane or axis. That means it goes this way, but not any other direction. Biaxial means at least two planes. Thumb's a good example for biaxial. And then multiaxial means many planes. Up, down, left, right, 360 degrees. But we're going to have some specifics. And I think these naming conventions are pretty intuitive. For example, your elbow, not between your radius and ulna, but between these two parallel bones and your humerus, that's a hinge joint. This is a hinge. It's a hinge. You guys know what a hinge is, right? Like the door hinge. It just opens and it closes. So that's a hinge joint. Ball in socket joint. There's a ball, there's a socket. It's a ball and socket joint, and that's going to provide a lot of movement. Your shoulder and your hip have a ball and a socket. The head, no, they might be. I'll have to think about it for a second. Because there's going to be a similarity between the structure and function of ball and socket versus a condylar joint. So a condylar joint, you know what a condyle is. It's going to be the sort of rounded head, right? And that rounded head is going to go into a concavity. So the only difference is degree, right? We're going to have an actual head of the femur going into the acetabellum of the os coxa, and that's a ball in a socket, versus a condyle in a fossa, right? So it's just this versus this. But generally it's going to give us the same idea of movement, where it's not a hinge joint. It can go in multiple axes. Let's go with axes. So does that make sense, the difference between condylar and ball and socket joint? Okay. Another variety of that is the saddle joint, and I kind of envision two Pringles, like the cracker, chip, we'll go with chip. So you have this concavity and you have this concavity, and they're going to be able to go in multiple directions around each other, like a saddle on a saddle. So that's a saddle joint, that's all. You have gliding or planar. I use those two terms synonymously. Your textbook uses plane joint, means a flat surface against a flat surface, and those can go against two axes at least, right? This can go this way or this can go this way. And then you have, in just a couple of unique places, a pivot joint. You know about your atlas and your axis already. You know that your axis has a dens or odontoid process, like a little tooth that sticks up and then articulates about against the atlas, and it lets you pivot your head and say no. So that's a pivot joint. Altogether, those types of motion are gliding, angular, rotational, or special, or just other. So far this semester, we've already seen regional anatomy terms. We've talked about the way joints can move. It turns out there are naming conventions that are specific to anatomy just for movements. And when those movements really come in handy is when we start talking about muscle actions in our next unit. But you need to start understanding them now. I'd say, aside from categorizing joints, understanding the vocabulary for joint movements is going to be the other part of studying this chapter. So let's go in order. And again, me and the textbook have a few disagreements here about what constitutes hyperextension. So flexion is actually decreasing an angle of a joint. Flexion of your arm at the elbow looks like this. Flexion of your arm at the shoulder is actually going to look like this. Extension is going to be the opposite. It increases the angle of a joint. And in some categorizations, extension is moving beyond the coronal plane, which is why this was flexion also. Here's extension. Here's extension, and here is also extension. Extension of the arm at the elbow, extension of the arm at the shoulder. Now, hyperextension, by my definition, is moving beyond the ordinary plane of a joint. By your textbook's definition, hyperextension is any movement of your head and neck posterior to the coronal plane, which I slightly disagree with. That would mean that this is hyperextension right here. So, gray area.
So what was your definition?
Hyperextension is moving beyond the extended form of the joint. So if you hyperextend your elbow, that means it had to pop out a little bit, right? Extending beyond the normal range of the joint. Their definition is extending beyond the coronal plane. Generally, in colloquial practice, if somebody hyperextended, they injured themselves, or they're in a position where they may have injured themselves. See, they have the same thing with your hands. Again, anatomic position, your hands are facing forward, your palms are facing forward, so they're calling that hyperextension. I just call that extension. Okay, lateral flexion There's only going to be a couple of places where you can laterally flex. It's that way. Now these words are abduction and adduction. I'm always going to say abduction and adduction and enunciate, because otherwise if I say it fast you can't hear me. So abduction is away from the midline of the body, and adduction is adding to the midline of the body. So abduction, abduction, and adduction, adduction, adding. I think that one's pretty easy because you can just imagine adding to that midline, and that gets you adding, adduction. Same thing with your legs, abduction, adduction. I'm not a big fan of calling this abduction or adduction personally. I don't think that makes sense because that's not the midline of your body, that's the midline of your hand. I don't know why they're saying that. This makes sense for abduction and adduction. This one does make sense. Circumduction really only works for things that are ball and socket or have quite a bit of mobility. Your shoulder joint, your hip joint can circumduct. That means going through that 360 degrees rotation that they can do. Lateral rotation, if your arm is bent, for example, this would be lateral rotation, this would be medial rotation, lateral rotation. Now take note, I showed you lateral rotation, medial rotation with my arm bent. It works just fine with your arm straight, lateral rotation, medial rotation. I'm still turning from here, but still lateral and medial. It's a little bit less obvious. And with your knee, note because your knee goes this way instead of this way, this is lateral rotation. My hip turned out laterally, but my foot is over here. And this is medial rotation, even though my foot is over here. So medial rotation, my hand ends up over here. Medial rotation, my foot ends up over there. Do you see how that's different? And trips some people up sometimes. And again, it works with your legs straight. Medial rotation, lateral rotation. Pronation and supination, for my purposes, is unique to the forearm and hands. The way that I say it is if you're supinated, you're holding soup. If you're pronated, you're prone to dropping your soup. This is supination, this is pronation. So again, if you are prone, who's heard of being prone? What position are you in if you're prone? Up or down? What's that motion mean? You're face down if you're prone, right? So your hand is face down if you're prone. Depression versus elevation. So this would be elevation, this would be depression. You can do it with your shoulders, you can do it with your jaw. You can bring your jaw up or down too. If it's open, then your jaw is depressed. If it's closed, your jaw is elevated. Has anybody ever heard of pronation and supination for feet? Like I run pronated, I run supinated. Has anybody heard that? If you're a runner, you may have heard that. It's technically an inaccurate use of the term pronation. You would use inversion and eversion for feet. It's a pet peeve of mine. Like, what do you do in runners? Using supination, pronation. Your feet don't do that. Your arms do. But, you know, it's very pedantic, so whatever. Your feet have some special movements. This is the dorsal surface of your foot. This is the plantar surface of your foot, like you plant it on the floor. So if you're dorsiflexing, dorsiflexion is moving it this way. Plantar flexion is moving it this way. They're both considered flexion. Your ankle is a very special joint. So these are both flexion. Flexion in the dorsal direction, flexion in the plantar direction. Does anybody ever do gymnastics and it's just like really hard to stretch these muscles effectively? Kind of know what I'm talking about. It's because, at least in here, there's always a muscle engaged, whether you're doing that or that. These muscles do both, dorsiflexion and plantar flexion. And again, since you can't actually supinate and pronate with your feet, it's eversion. The plantar surface of my foot is facing this way if you can't see it, and inversion. Plantar surface of my foot is facing medially. Protraction and retraction, this is another thing your jaw can do. You can protract and retract your jaw. Opposition is unique. Opposable thumbs. You've heard of the phrase opposable thumbs. Humans have opposable thumbs. That makes us relatively special. This is opposition, and it's just with thumbs. These don't just give you movements and skeletal muscle actions. Some of them also give you names. It's actually not a muscle you're responsible for, but you have a muscle called opponens pollicis. So what's pollex? The thumb. And then what's opposition? It's going like this. So you have muscles that are just specifically responsible for making your thumb act in opposition to other fingers, opponens pollicis. So that's how naming of muscles can sometimes work, based on, in some cases, action. All right, what am I doing with my shoulders? Elevation. Now what am I doing with my shoulders? Depression. There we go. What am I doing with my arm at the shoulder? Extension. By my definition. What am I doing by the textbook's definition? Hyperextension. Good. What am I doing with my arm at my elbow? Flexion. And then extension. Good. What am I doing with my thumb? Opposition. What am I doing with my jaw? Protraction. And then when it comes back, it's good, retraction. My arms, my hands, my forearms and hands are currently supinated, and then now they're pronated. And again, that works here too. This is supinated, this is pronated. You just can't do the soup thing like this. So I prefer to do it like this for demonstration purposes. My foot is currently what? Not everted, inverted. Now my foot is everted. Good. Now my foot is plantar flexed, and now my foot is dorsiflexed.
So with the extension, shall we go by your definition?
Again, there's not going to be an exam scenario where that comes into play.
Okay.
I've eradicated those disagreement sites. Okay, some selected joints. What time is it? It's kind of a weird time, but we're going into a new topic, so I kind of want to stop here and go on.